What you are about to see is a video animation describing the circumstances that cause the condition known as frozen shoulder syndrome. Recent research and patient outcome studies point to a different cause for frozen shoulder syndrome than once thought. The shoulder joint is a complex structure that employs the use of many other joints and muscles to conduct the full range of movements realized in a healthy shoulder joint. Normally, the upper arm bone, known as the humerus, can move freely in abduction 180 degrees. Frozen shoulder syndrome sufferers have a severe loss of abduction, usually accompanied by considerable pain. The first 120 degrees of abduction occurs freely without obstruction. At 120 degrees, the humerus runs directly into the acromion process of the scapular bone and the soft tissues, which lie just inferior to the acromion process. Upon normal abduction of the upper arm, at 120 degrees, the serratus anterior and trapezius muscle engage the scapular bone and rotate it upwards. This action allows the humerus to abduct the remaining 60 degrees so that the full 180 degrees of abduction can be expressed. The problem in frozen shoulder syndrome occurs in the malfunction of the trapezius muscle. To fully understand the malfunction of the trapezius muscle, we must travel to the skull and the cervical spine. The trapezius muscle receives its vital information from the spinal accessory nerve, cranial nerve 11, which emanates in the brainstem and upper cervical spine. The scenario of events that triggers frozen shoulder syndrome begins with the skull becoming locked in a single position and is guided there by a series of biomechanical movements. These movements are head extension, looking upward, lateral flexion, ear toward the shoulder, and rotation to the opposite side of the lateral flexion. This condition locks the head in an upward gaze. The righting mechanism of the nervous system drives the lower cervical spine into forward flexion. This position allows the head to face forward and the eyes to find the horizon line. This position also gives the subject a visibly head-forward posture. The combination of the head being locked in extension and the lower cervical spine forced into flexion creates a tethering of the brainstem and upper cervical spine. If the tethering force is great enough, any nerve aligned in the tethered area will undergo a state of neuropraxia, or motor paralysis, ischemia, or reduced blood flow, and inflammation. The affected nerve cannot function normally. When the nerve involvement includes the spinal accessory nerve, impaired function of the trapezius muscle occurs, and consequently, the shoulder movement is affected. When this biomechanical relationship of the skull on the spine is corrected, and normal tension and blood flow are restored to the brainstem, the nervous system usually returns to normal. The frozen shoulder syndrome is broken, and the process of rehabilitation can begin.